Good day, doctors. Today we will discuss emergency medical care and dental practice. Макушева Наталья Вячеславовна. Objective: to study the emergency medical care of patient during a dental appointment and how to provide first aid. Lecture questions: what is an emergency? Types of emergency conditions, first aid, and a set of medicines for emergency care. Relevance: dental care is one of the most widely used by the population. Anatomical, physiological, and topographic features of the maxillofacial region is the beginning of the respiratory or digestive tract, directly adjacent to the brain. Organs of visions, hearing, smell, as well as intensive blood supply, innervation, the presence of powerful reflexogenic zones cause a high risk of developing emergency condition in dental practice. Therefore, a dentist must be able to diagnose and provide emergency care for all types of asphyxia, bleeding, pain, collapse, shocks, and other emergency conditions. What is the difference between first aid and emergency medical care? The task of first aid is to elevate the condition of the victim, prevent complications, and often save life itself. Unlike first aid, medical care is a set of measures aimed at maintaining and/or restoring health and including the position of medical services, medical intervention, or a complex of medical interventions. So, emergency medical care is medical care providing in case of sudden acute diseases, conditions, exacerbations of chronic diseases that pose a threat to the life of the patient, which is provided by any medical organization and medical worker to a citizen immediately and free of charge, and refusal to provide it is not allowed. Thus, a dentist must be able to provide emergency medical care to a patient in a dental chair and in need of this type of assistance. Failure to provide emergency medical care by a doctor entails criminal liability. Frequently used grounds for holding dentists criminally liable. Article 109. Causing death by negligence up to 2 years. Causing grievous bodily harm through negligence up to 3 years. Failure to provide assistance to the patient up to 4 years. Neglect of one's duties or improper performance of them up to 7 years. All of the above articles involve additional punishment in the form of a ban on professional activities for up to 3 years. So, emergency care is needed for emergency and terminal conditions. Pathological conditions in the body can be divided into 3 groups. The first group is planned pathological conditions, provision of medical care in which they are provided in a planned manner. The second group is emergency conditions, conditions that pose a threat to life and require urgent, within minutes hour, therapeutic measures. And the third group is the terminal states, Borderline states between life and death. A critical level of life dysfunction with a catastrophic decrease in blood pressure, a profound disruption of gas exchange and metabolism, pre-agony, agony, and clinical death. And the first medical emergency, we are going to look at a syncope. Syncope is an attack of short-term loss of consciousness caused by incoming cerebral ischemia associated with a weakness of cardiac activity and an acute dysregulation of vascular tone. Etiology. Factors causing a sudden decrease in the volume of blood entering the cerebral vessels can be decrease in cardiac output with myocardial infarction, massive acute blood loss, several arrhythmias, ventricular tachycardia, bradycardia, hypovolemia due to the profuse diarrhea, or narrowing of the lumina of the arteries supplying the brain, with atherosclerosis, occlusions of carotids, vascular spasm, or dilatation of blood vessels, a rapid changing in body position, for example, orthostatic collapse, a changing in the tone of the vessels, dilatation or spasm, supplying the brain is often of a neuroreflex nature and is the leading cause of syncope. Such a syncope can provoke a strong physical emotional experience, pain, irritation of the carotid sinus, for example, coughing, swallowing, sneezing, and the vagus nerve, for example, during otoscopy, gastrocardial syndrome. An attack of acute cholecystitis or renal colic, trigeminal neuralgia, glossopharyngeal neuralgia, an attack of vegetative vascular dystonia, overdose of certain pharmaceuticals, etc. Another mechanism that provokes syncope is decrease in blood oxygenation. A decrease in the oxygen content in the blood with normal. Syncope of this genesis can be observed in blood diseases, iron deficiency anemia, sickle cell anemia, etc. Carbon monoxide poisoning, respiratory diseases, bronchial asthma, obstructive bronchitis, etc. A decrease in blood oxygen can also cause syncope, which is often observed with hyperventilation of the lungs. According to some reports, about 40% are syncope, the etiology of which has not yet been established. The pathogenesis of syncope is associated with a short-term decrease in the venous tone of the vessels of the lower extremities and the abdominal cavity, with the development of relative hypovolemia. That is, the volume of circulating blood becomes relatively small for the vascular bed and blood is deposited in the periphery. This causes a decrease in venous return and a drop in cardiac output, and as a result, the violation of the blood supply of the brain with the development of its hypoxia. Diagnosis of the condition will consist of anamnesis, presyncopal precursors, and the condition itself. Anamnesis. Circumstances under which a syncopal episode developed. Posture change during after exercise, during or immediately after coughing, defecation, long stay in a standing position, in a stuffy or damp room, the presence of provoke factors, fear, severe pain, neck movements. Stage and clinical signs. Presyncope, characterized by increasing weakness, dizziness, nausea, kindling in the ears, flashing flares before the eyes, feeling short of breath. The next stage is loss of consciousness, syncope, 3-5 minutes, characterized by brief total loss of consciousness, decreased muscle tone, pale skin, decreased blood pressure, and bradypnoea. And the next stage, recovery. Consciousness is restored quickly. There are no symptoms of organic damage to the nervous system, lack of disorientation, retrograde amnesia, dizziness, weakness, hyperhidrosis may persist. Immediate measures for syncope. The first one is give the child a horizontal position with the foot and rise it by 50-60 grade. Second step is relax the restrictive elements of clothing, collar, belt, etc. Third, use reflex effects. Irritating therapy. Wet the face with cold water. Let the patient breathe in vapors of ammonia or vinegar. Fourth, in case of severe arterial hypertension, prescribe a 1% solution of mezotone. In case of prolonged syncope, introduce cardiamine 0.5 to 1 ml subcutaneously, or 10% solution of coffee sodium benzoate 0.1 mg per kilogram subcutaneously too. In case of syncope due to hypoglycemia, inject 20 ml of 40% glucose solution intravenously. If the syncope with bradycardia, take a 0.1% solution of atropine 0.1 ml per kilogram intravenously. With syncope of cardiac origin, as well as an unclear etiology of syncope, hospitalize the child. Prevention of syncope. People who are prone to syncope should avoid situations that cause them to occur. Calm down and don't panic. Eating regularly and drinking enough fluids also help prevent syncope. If you feel the approach of syncope, then you need to lie down and raise your legs up. This will increase blood flow to the brain. When it is not possible to lie down, you can sit down and put your head between your knees. The next emergency is collapse. Collapse is a type of acute cardiovascular insufficiency caused by a sharp decrease in vascular tone and developing relative hypovolemia. Etiology. The phenomenon can occur with toxic damage to the vasomotor center, disruption of the receptor apparatus of large arteries and venous, inability of the heart to provide the necessary volume of blood ejection, insufficient amount of fluid in the circulatory system. Pathogenesis. The pathogenesis of collaptoid states is based on a pronounced discrepancy between the throughput of the vascular network and the volume of circulatory blood. Expanding arteries do not create the necessary resistance, which leads to a sharp decrease in blood pressure. A drop in blood pressure leads to a weakening of the perfusion of gases in tissues. An insufficient supply of oxygen to cells, ischemia of the brain, and internal organ due to a mismatch between the metabolic needs of the body and the level of its supply with oxygen. The following clinic phases of collapse can be distinguished: sympathotonic, vagatonic, and paralytic. The sympathotonic phase is very short-lived. The violation of peripheral circulation is due to spasm of arterioles and centralization of blood circulation. Later, in the vagatonic phase, there is a significant expansion of arterioles and arteriovenous anastomosis, which lead to the deposition of blood in the vessels of the microvasculature. Paralytic collapse is consequence of the deflation of the mechanism regulating blood circulation. Clinical collapse most often develops at the peak of the underlying disease. The child condition is deteriorating rapidly. Severe weakness, dizziness, chills, the lethargy of the child increases, indifference to the environment, up to adenomia. Consciousness is provided, as opposite to syncope and shock. Severe pallor of the skin, Lyme's cold, acrid cyanosis, tachycardia, 3D pulse, muffled heart sounds, blood pressure is reduced, collapse, peripheral venoms. In young children, collapse against the background of severe infection can occur with the development of convulsive syndrome and loss of consciousness. The first aid: give the child a horizontal position. Ensure the patency of the upper respiratory tract. Relax the restrictive elements of clothing. Introduce intravenous prednisolone at a dose of 2–3 mg per kilogram. Start fluid therapy at a dose of from 5 to 8 mg per kilogram, a 0.9% sodium chloride solution. With presence hypotension, administer in intravenous 1% solution of mesotone or adrenaline at the rate of 0.1 per year of life. Next step is hospitalization of child. Preventive measures of the collapsed state include timely detection of disease, treatment of disease, regular monitoring by a doctor, compliance with all recommendations of the attending doctor, the use of any medicines only after full-time consultation with the doctor, reduction of bad habits, avoidance of exposure to pathological environmental factors. The next emergency is allergic reaction. Under allergic reaction, understand that increased sensitivity of the body to various agents due to a change in its reactivity. In most cases, drug allergy encountered in the practice of a dentist is based on an immunoglobulin E-mediated allergic reaction. Immediate type, hypersensitivity. The hypersensitivity of the body is based on the sensitization of the body to a specific antigen. The most common allergic reaction in dental practice develop on the introduction of local anesthetics. But from the previous lecture, we know that parabens and sulfates containing in the anesthetic carpel are more likely to cause allergies. In any case, before prescribing or administering any medication, it is necessary to find out the patient's allergic anamnesis and sign an informed voluntary consent of anesthesia. Increased attention should be paid to children with a history of various diseases of allergic and or infection allergic genesis, bronchial asthma, rheumatism, eczema, etc. In such children, the possibility of using antihistamines, suprastin, Tavigil, etc. as a premedication, and in some cases hormonal agents, prednisolone, hydrocortisone, etc. should be considered. When choosing a drug for local anesthesia, one should take into account not only the main active agent, but also the preservative used. Allergic reaction can be local and systemic. Among local reactions, skin lesions are most often observed in drug allergies. Hives, Angiodema, Quincus edema. Allergic hemorrhagic vasculars contain dermatitis. Artus-Sakharov phenomenon, exfoliative erythema, acute generalized exanthemus pustulosus. Local allergic reaction from other organs and systems are much less common. Types of local lesions of internal organs and system in allergic reaction can be at respiratory system, for example, rhinosinusitis, bronchospasm, pulmonary esophageal Leffler's syndrome, pneumonia. At hematopoietic system, hemolytic anemia, thrombocytopenia, agronucleocytosis. At circulatory system, extremely rare, myocarditis, for example. Gastroenterical tract, gastroenterocolitis, acute hepatitis, polystasis. Kidney system, very rare. Acute interstitial nephritis, glomerulonephritis. And nervous system, peripheral neuritis. Systemic lesion in allergic reaction often manifest as anaphylactic shock, acute severe with dermatosis, malignant exudative erythema, Stevens-Johnson syndrome, toxic epidermal necrolysis, Leila's syndrome, systemic drug vasculitis, etc. Types of skin lesion in allergic reaction. Hives, characterized by rapidly appearing blisters of various size and localization. Itching, may be single or multiply, pale pink in color. Angiodema or Quincus edema, swelling in place with developed subcutaneous tissue, more often eyes, lips, etc. Painless, without itching of the skin and discoloration of the skin. Next type of skin lesion is allergic hemorrhagic vasculitis. Allergic hemorrhagic vasculitis characterized by petechial rash, which has a symmetrical localization. More often, the anterior and lateral surfaces of the legs, thighs, buttocks. Less often, forearms and shoulders. Lesions of the face and neck are not typical after prolonged hyperpigmentation. Next type of skin lesion is contact dermatitis. At the site of contact with the allergen, redness, sweating, papules, and vesicles may occur at the site of exposure. Arthur-Sakharov phenomenon. Reaction in the form of infiltration, itching, redness, which manifests itself after 7 days or even 1–2 months after the administration of the drug. Exfoliative erythema. Redness and peeling of the skin of a common nature, combined with generalized lymphadenopathy and fever. Acute generalized exanthemosis pustulosis. The development of widespread pustular rash against the background of erythema, combined with fever and increase in the number of leukocytes in the general blood test. Pathogenesis of the allergic reaction. Hypersensitivity due to immune mechanism is referred as allergy, and the substances that cause it are called allergens. Allergic reaction can differ significantly from each other, primarily in the time of their manifestation after repeated contact with the allergen. In accordance with this, immediate type hypersensitivity reaction developing after a few minutes and delayed type hypersensitivity reaction developing after 10 hours and later are isolated. According to the classification of Gell and Coombs, all allergic reactions depending on the mechanism of developing are divided in four types. The classification is conditional, since different types of tissue damage can occur simultaneously or place each other. Hypersensitivity reactions of the first type are caused by the interaction of the allergen in immunoglobulin E adsorbed on the membranes of the mast cells and basophils. Therefore, these reactions are also called immunoglobulin E mediated. Due to its ability to react with the surface of most cells and basophils, immunoglobulin E is also referred to as reagents. This property is called cytophilicity. Cytophilicity of immunoglobulin E is due to the presence of special receptor structures in the antibody molecule. In the interaction of the allergen with immunoglobulin E adsorbed on mast cells and basophils leads to the release of biologically active substances, for example, histamine, serotonin, eosinophilic and neutrophilic hematocytic factors, and proteases. These substances are formed before contact with the allergen. After the interaction of the allergen with immunoglobulin E, new mediators are synthesized. Platelet activating factor PIF, slowing reactant anaphylaxis substance glycotriene B4, C4, and D4, and other metabolic product of cell membrane, phospholipids, prostaglandins, and thromboxanes. Mediators interact with receptors in muscle, secretory, and many other cells, which leads to contraction of smooth muscles, for example bronchi, increased vascular permeability, and edema. Clinically, a reaction of the first type are manifested mainly by anaphylaxis and atopic dermatitis. Less commonly, acute urticaria and angioedema are observed. Treatment of allergic reaction largely depends on the form of the disease and the causative factors. However, the basic principles of therapy are the same. They include the following steps. First one, this is the exclusion of the effects of drugs that cause an allergic reaction, and secondary pharmacotherapy. Patients with a local allergic reaction, in order to relieve an acute condition in most cases, are shown oral administration of second-generation antihistamines, loratadine, terfenadine, astramazole, etc., approved for children of one or another age group. In a more severe course of disease, parenteral administration of antihistamines, diphenhydramine, suprastrine, etc., as well as glucocorticoids is advisable. With systemic manifestation of allergens, hospitalization of the child is mandatory. Prevention of allergic reaction at a dental appointment is careful collection of allergic anamnesis. Anaphylactic shock. Anaphylactic shock. Anaphylactic shock is an allergic reaction of an immediate type which develops with the repeated introduction of an allergen, foreign proteins, medicines, insect bites, etc. This is systemic allergic reaction, characterized by the rapid development of life-threatening breathing and or circulatory problems. This is one of the most dangerous complications of drug allergy, ending in approximately in 10% of cases is fatal. The pathogenesis of the development of allergic reaction of the first type associated with the formation of immunoglobulin E we considered above. The rate of occurrence of anaphylactic shock is from a few seconds or minutes to several hours from the start of contact with the allergen. In the development of an anaphylactic reaction, neither the dose nor the method of allergen administration play a decisive role. Any diagnosis, as you know, is made on the basis of the survey, taking anamnesis, collecting compliance, and data of basic and additional method of examination. So, anamnesis, the presence of allergic disease, taking drugs with a high sensitizing activity, long-term use of drugs, especially repeated course, use of depot preparations, polypharmacy, prolonged professional contact with medical and chemical means. According to clinical options, anaphylactic shock can be of different types. Depending on this, compliance and clinical data will differ. The types of anaphylactic shock are as follows: typical, hemodynamic, collaptoid, asphyxia, cerebral, and abdominal. In the table, you see typical patient compliance and clinic manifestation depending on the type of anaphylactic shock. Typical: an acute state of discomfort in the form of vague painful sensation with excitement and anxiety, severe weakness, dizziness, disorder of consciousness, sensation of a rush of blood to the head, tongue, and face, sensation of tingling and itching of the skin of the face, hands and head, headache, labored breathing, sharp cough, pain in the heart or palpatories, feeling of heaviness behind the sternum or chest compression, nausea, vomiting, pain in the abdomen, and clinic, frequent therapy pulse, tachycardia, head sounds and muffled, blood decrease rapidly in several cases, respiratory failure, pupils are dilated and unresponsive to light, hemodynamic or collaptoid, compliance, variant with the predominance of hemodynamic disorders with the development of severe hypotension and vegetative vascular changes. And compliance will be severe pain in the heart. Clinic, a sharp decrease in blood pressure, weakness of the pulse and its disappearance, violation of the heart rhythm, spasm of peripheral vessels, pallor, or the expansion, generalized flaming hyperemia, and microcirculation dysfunction, marbling of the skin, cyanosis. The next type is Asphyxial variant. Compliance, cough, hoarseness of voice, suffocation, and clinic, development of laryngeal and or bronchospasm, edema of the larynx with the appearance of signs of severe acute respiratory failure, development of respiratory distress syndrome with severe hypoxia. Next type is cerebral variant, appearance of fear and excitation and clinical, development of convulsive syndrome, psychomotor agitation, impaired consequence of the patient, respiratory arrhythmia, vegetative vascular disorders, meningeal and mesencephal syndromes. And the last one, abdominal variant, with the development of symptoms of the so-called false acute abdomen, with compliance on sharp pains in the epigastric region and clinic presence of sign of irritation of the peritoneum. In acute malignant shock, there is no period of compliance. There is sudden loss of consciousness and cardiac arrest and clinical death. Emergency care for anaphylactic shock consists of 3 areas of action. The first one, there are measures to stop the entry of the allergen into the bloodstream. To do this, it is necessary to isolate the injection site. Among these activities are tourniquet or epinephrine injection site injection or bite. The next direction is anti-shock measures, which will be injection of adrenaline intravenously, if not possible sublingually. Next one, this is necessary in case of a rapid decrease in pressure and infusion therapy. The third direction is anti-allergic therapy, injection of glucocorticoids. Providing emergency medical care in the event of anaphylaxis shock step by step. First, blood pressure control. Second, call an ambulance. Third, prick the injection site with adrenaline. Fourth, inject adrenaline intravenously 0.1% starting with 0.5 milliliters. Mandatory. Infuse of adrenaline. Stimulate blood circulation. Inhibits degranulation of most cells. Drip or spray. The dose depends on the severity of anaphylactic shock and initial dose. The first dose, a half of milliliters, 0.1% solution. Step 5. Ensuring airway patency. 6. Replacement of circulatory blood volume by intravenous drip of crystalloid or colloid solution, and carrying out resuscitation measures. When signs of clinical death appear, resuscitation measures are performed according to the standard algorithm. 7. The use of antihistamines, diphenhydramine or suprastin intravenously. 8. The use of glucocorticoids drug, prednisolone, dexamethasone intravenously. And 9. Oxygen inhalation. It is mandatory to maintain a written protocol for the provision of first aid of emergency medical care. Prevention of allergic reaction at a dental appointment is careful collection of allergic anamnesis and premedications. Next emergency is Angiodema or Quincke's edema. Angioedema or Quincke's edema is a reaction to various biological and chemical factors, often of an allergic nature. Angioedema manifests itself the skin in the subcutaneous tissue and on the mucous membranes of the internal organs of patient. Quincke's edema is dangerous primarily by spreading to the larynx due to compression of the trachea and respiratory failure. The disease is named after the German physician Henry Quincke, who first described it in 1882. Quincke's edema is characterized as allergic reaction of immediate type, rapidly developing limited swelling of the skin, subcutaneous tissue, and mucous membranes. May accompany urticaria or acute in isolation. May be part of a generalized anaphylactic reaction. Diagnostic. An infiltrate is formed more often in place with lost fiber on mucous membranes, most often in the area of lips, centuries, scrotum, oral mucosa. It happens. Various size, pale, slightly itchy, dense, and palpation doesn't leave a hole. Especially dangerous is the swelling of the pharynx, which can lead to asphyxia. When it appears, will be breaking cough, increasing hoarseness of voice, difficult noisy stroid breathing, cyanosis, and then facial pallor. Tactics of a doctor in the development of angioedema in a patient. First, eliminate the allergen. Second, check airway patency. If necessary, emergency intubation or tracheostomy. Third, monitoring of hemodynamic parameters. Fourth, glucocorticoids, prednisolone from 60 to 100 milligrams intravenously by both. 5. Antihistamines, phenystyl intravenously, diphenhydramine, suprastin, tavigil intravenously from 1 to 2 milliliters each. In the presence of suspicion of laryngeal edema or anaphylactic shock, intravenously 0.1% adrenaline solution, starting from 0.3 milliliters. And seventh, with laryngeal edema, urgent hospitalization in a hospital. In case of asphyxia, when the patient doesn't breathe and the ambulance still came, the conicotomy or cricoconicotomy is performed. Conicotomy is a median incision of the larynx between the cricoid and thyroid cartilages within the cricoid ligament. Then a hollow tube is then inserted into the incision to provide breathing. The next emergency is asphyxia. Asphyxia is the oxygen starvation of the body, which occurs, for example, when the airways are closed from the outside, closing the lumen, etc. With all types of asphyxia, the increase in the clinic of acute respiratory failure occurs in the following sequences. The first phase will be lengthening and straightening of inspiration and will be characterized by inspiratory dyspnea, anxiety, cyanosis, and tachycardia. Second phase, decrease in breathing with a sharp increase in exhalation, will characterized by expiratory dyspnea, acute cyanosis, bradycardia, increased blood pressure, and cold sweat. Third phase, bradypnea, loss of consciousness, and fourth phase, abnormal breathing and apnea. Asphyxia can be different types: dislocation, obstructive, stenotic, valve, and aspiration. So, the asphyxia is an acute violation of external respiration as a result of a mechanical obstruction in the upper respiratory tract. And dislocation, asphyxia develops as a result of overlapping of the airways with the tongue due to its displacement positorily. It is observed with fractures of the lower jaw in the chin area, or when the epilepsy or something else. Emergency care for dislocation asphyxia consists in laying the victim on his side, on the side of injury, or placed down so that his mouth and nose don't touch a hard surface, ground, stretcher, etc. To prevent the tongue from falling off, its tip is stitched with a thread, which is fixed on the outside. If the tongue has significant damage, then the second paragraph may be not effective. Obstructive, the next next type of asphyxia. In children, asphyxia is most often possible due to airway obstruction by a foreign body. Cough is the most effective mechanism for dealing with foreign body obstruction in the airways. If the child has a cough, when special mechanical methods to remove foreign bodies from the respiratory tract are not used. The algorithm for conducting urgent measures for obstruction of the respiratory tract by a foreign body in children is presented. Re-evaluation of cough effectiveness. Cough can be effective and ineffective. If the cough is effective, We stimulate cough and observation dynamic of the state of the person. If the cough is ineffective, we see if the child conscious, we do 5 sharp blows to the back, and then if this 5 sharps is ineffective, we do Heimlich maneuver. If the child is unconscious, we ensure the patency of the upper respiratory tract and then start CPR. Mechanical method for removing foreign body children under 1 year old. First, the child is placed on the left forearm of the person, assisting with the stomach down so that the child's face is in the palm of the resuscitator. The forearm of the person providing assistance should be lowered from the horizontal level at an angle of 60-70% or 60-70 grade. With the right hand, with the edge of the palm, 4 short blows are applied to the interscapular region of the baby. If the above method fails, the following procedure is used. The child is given a supine position on a hard surface. The middle and index fingers of both hands are placed in the epigastric region of the child. Vigorously sharp push on the epigastric region in the upward direction of the diaphragm. This procedure is repeated up to 5 times. When carrying out this technique, it should be controlled that pushes don't fall on hypophoid process or lower ribs, as this can lead to traumatic damage to the abdominal organs. Children over 1 year old. In children older than 1 year, if there are signs of obstruction of the upper respiratory tract caused by a foreign body, first 5 strokes are performed on the interscapular region. Further, in the absence of a positive effect, the Heimlich maneuver is used. If the child is standing, you need to take a position behind his back, kneeling, and wrap your arms around his chest. In this case, the hands of the assisting person must be positioned as follows. The inner surface of the thumb of the hand, climbed into a frost, is located on the anterior abdominal wall in the epigastric region, at the level of the medial of the distance between the xiphoid process and the navel. The palm of the second hand in the placed on the top yourself. Each jerk performed must be sufficiently sharp and jerky. If an adolescent child is unconscious and can't be approached from behind, the following technique might be used. The first, lay the child on the hard, flat surface. Take a position astride the child's hips, facing the child's head. The head should not be turned. Putting one hand on the other, place the base of the palm of the lower hand on the epigastric region. Using the weight of the body, vigorously and sharply press on the epigastric region in an upward direction downward the diaphragm. This technique is repeated up to 5 times. Stenotic type of asphyxia develops with an increase in hematoma edema, or the pharynx or larynx. First aid for quincus edema we discussed above. Valvular asphyxia. When the entrance to the pharynx is closed with a flap of soft tissue. Valve asphyxia is a rare case of asphyxia during injuries that occurs during combat operation, accidents, etc. First aid for valvular asphyxia is to remove some of the tissues that create the valve and interfere with the movement of air. Aspiration types of asphyxia occurs when blood and vomit enter the respiratory tract. The first aid to aspiration type of asphyxia. Turn the victim on his side. Clean his mouth with a finger from vomit. Check the breath. And the last type of emergency for today is terminal stages. Count Hoven says, anyone, anywhere can start CPR. All you need is 2 hands. And Peter Safar says, head and brain are too good to die. Terminal states are reversible states of extension of body function that precede biological death and include the preagonal state, a terminal pause, and agonal state, agony, and clinical death. Predagonia. Impaired consciousness, abnormal breathing, decreased blood pressure. Agony characterized by unconsciousness, agonial breathing, pulse only on the carotid arteries, on the carotids, and clinical death. Clinical death characterized by lack of consciousness, breathing, blood circulation. This is a reversible state, but it's reversible at 3-5 minutes. What is the difference between clinical and biological death? If clinical death is a reversible state, that and biological death is irreversible state. It characterized by reliable signs, cadaveric spots, rigor mortis, symptom of cat's eye. In the event of clinical death, cardiopulmonary resuscitation should be performed. Cardiopulmonary resuscitation, CPR, is not carried out in the presence of signs of biological death and doesn't carried out upon the onset of a state of clinical death against the background of the progression of reliably established incurable diseases of incurable consequences of an acute injury incompatible with life. CPR stops when the ineffectiveness of resuscitation measures aimed at restoring vital function within 30 minutes. CPR can be of 2 types, basic and extended. Basic type consists of temporary replacement of ventilation and circulation without the use of special equipment carried out by any person in any conditions. And extended CPR is complete restoration of ventilation and circulation with special equipment and any stuff. Steps of basic CPR. assessment of the situation, conscientious assessment, airway patency, breath assessment, compressions, artificial lung ventilation. Assessment of the situation. Make sure you and the victim are safe. Eliminate any risk to yourself and the victim. Primary care risk. The injured by yourself and environment. Traffic, electricity, gas, water, smoke, fire, etc. Consciousness assessment. Loud question, movement evaluation, and pain assessment. Gently snake your patient's shoulders and ask loudly, "Are you okay?" and call for help. The next step is open airways. In the picture you see respiratory tract on a selection of the head. If head not tilted, close airways. So if head through back, the airways is open. And when you do emergency medical care, you have to do open airways through head back. Next step, head tilting. Tilt the head of the patient back and pull the chin of the patient, of the victim, up. On the slide you see how to do this manipulation right. Removal of foreign bodies from the respiratory tract. Cleansing the mouth with a finger. Breath assessment. Next step. For evaluation adhere to the principle I see, I hear, I feel. I see chest movement. I hear the sound of breathing, and I feel the movement of exhaled air. Okay, you see that the victim is breathing normally, then place the victim in the lateral recovery position, call for emergency medical assistance, and continue assessing status. If the victim is not breathing or breathing is abnormal, ask for an ambulance and notify the dispatcher the victim is unconscious and not breathing. Next step is check circulation assessment and carotid pulse. With connected 2, 3, and 4 fingers, find the Adam's apple. Then slide the fingers along the edge of the Adam's apple in the side of the rhinocleidomastoidal muscle. Then feel for the carotid artery. All previous stage can do maximum at 10 seconds. And next step will be chest compression. Stand next to the victim, arms straight. Find the xiphoid process. Place the base of the palm in the center of the cachealis chest. Lower palm along the body from the sternum. Place the base of your other hand on top of the first. Apply pressure to the sternum to a depth of 5 centimeters. Release chest compressions completely after each compression. Compression rate is 100 per minute. Perform 30 chest compression. Next step, artificial lung ventilation. Tilt the victim's head back, take a calm breath, pinch the soft part of the victim's nose with 2 fingers. Exhale calmly into the victim's mouth, tightly clasping his mouth with your lips. Inspiratory time is 1 second. Volume about 500–600 milliliters. Watch the rise and fall of the victim's chest. Give 2 rescue breaths. Continue chest compression and rescue breath at a ratio of 30/2. 30/2. Continue chest compression and rescue breath at ratio of 30/2 before the arrival of the ambulance until normal breathing is restored. Stop to check status. Stop only when there are signs of life, breath, motion, or cough. Assess the victim's breathing. If the victim is not breathing, continue chest compression and rescue breath at a ratio of 30/2. If several rescuers provide assistance, alternate CPR with a colic every 1–2 minutes to reduce fatigue. The pause in CPR during the change of rescuers should be minimal. CPR algorithm. Check reaction. If the victim doesn't react, open airway and check breathing. If the victim doesn't breathing, call 112, continue compression and artificial lung ventilation, 30/2. If there are breathe normally, call 112, lay lateral recovery position and observation. Efficacy of artificial lung ventilation and chest compression will be pupil construction, decreased cyanosis, and pulsation of large artery according to the frequency of message. The appearance of spontaneous breathing is the good sign. Restoration of independent heart contraction, providing sufficient blood circulation, will be manifest like appearance of pulse in the peripheral arteries. Efficacy of artificial lung compression, lung ventilation and compression. Frequency, depth, decompression, continuity, and ventilation. Remember that the life of the victim or patient depends on the correctness of action in an emergency situation. Our lecture is over. Thank you for the attention.